was a software engineer by occupation, presented to OPD with history of numbness over the right thumb. History of numbness over the right thumb 14 days back. Numbness progressed on to involve on the other fingers over the next 4 days. However, he was able to differentiate hot and cold. Then,
hello?
Yes, sir.
First slide. I am still in the first slide. So presented with history of numbness over the right thumb. Okay.
Yes, sir.
So progress to involve the other fingers in the next few days.
Yes, sir.
So if you had seen the patient on that day, what would be your thought process? Yes, numbness over the right thumb on the day one. So
probably at this point could be carpal tunnel syndrome.
I don't want diagnosis. I want you to think logically. So numbness is what? It is a sensory.
Peripheral nerve compression.
It is a negative symptom of a sensory fibers.
Okay, sir.
That is what must start with that. And then where all it could be. It could be in the median nerve at the wrist.
Median.
It
Yes,
can
sir.
be, which is the
it
next.
Could be.
Pardon?
Hello?
It could be median nerve at the wrist, or which is the next common site where the patient can come with.
Elbows. Elbow.
Elbow what nerve, madam? Elbow is what? You don't
radial nerve
compression in elbow. It is the ulnar nerve compression. Okay. Understand?
Yes.
So that's why the whole point is that I want you to scientifically analyze it. So right thumb, as you rightly said, is supplied by the median nerve. So it is a negative sensory symptom. And it could be as distal as the carpal tunnel, which is the next common site where patients come to OPD complaining of numbness, tingling of thumb and index finger.
Ulnar.
How can thumb be supplied by ulnar nerves? Basics. The next common site is the C6 root cervical spondylosis.
Okay, sir.
Patients with cervical spondylosis and C6 root, they come with neck pain and numbness of the thumb and index. So when a person comes to the OPD complaining of numbness of thumb and index, you should ask whether the patient also has neck pain. If there is a neck pain and thumb and index or only thumb numbness, it is a C6 root, sensory root. But if the patient is on hyperextension of the wrist, has got numbness, then it is the carpal tunnel. I have seen patients with carpal tunnel being operated for cervical spondylosis because clinically it has not been localized. The whole presentation, the whole discussion of these meetings are to train you people to think logically, not jump to the diagnosis. Patient has cervical spondylosis, patient has carpal tunnel. We don't want diagnosis. You understand?
Okay.
So it is a negative symptom and of a sensory nerve. So either it can be a nerve that is in the median nerve at the carpal tunnel, or it can be in the sensory root at the cervical spine. So these are the two common locations for patients complaining of numbness. So at that point of time, what will you do? Patient has just come to you for numbness. You have examined the patient. There is a slight decrease in the sensory, which he complained of, which you objectively have found out. What will you do for him at that time?
Associated weakness, grip weakness.
No, reflex, nothing will be found. If the patient has neck pain, then if the C6 biceps reflex may be absent, then you can say it is a cervical left C6 sensory radiculopathy.
Yes.
So what you have to do is don't jump for any investigation like MR cervical spine or carpal tunnel syndrome. You ask for nerve conduction simply because many people have asymptomatic carpal tunnel syndrome and many more people have cervical spondylosis radiologically. So the presence of investigation, either spondylosis or carpal tunnel, does not mean your diagnosis is right. The diagnosis is on clinical. So one of the important clinical tests is in the OPD, ask the patient to stand with both the upper limbs hanging down and ask him to extend the neck. When he extends the neck, if the root is compressed, he complains of increased numbness and tingling of thumb and index, thereby confirming clinically that it is a spondylotic radiculopathy. You understand?
Okay, sir.
You might have seen me doing it in the OPD when you were there, or you might have forgotten. But this is a very important clinical point. Hyperextension of the neck reproducing the patient's symptoms shows that it is a radiculopathy. Okay.
Okay. Yes, sir.
But how will you treat him at that time? Just give a symptomatic therapy, no matter how much the protrusion of the C6-7 disc collapse. Just give him the symptomatic therapy and train him for the isometric neck exercise. There's no need to do any operation just because spine shows C6-7 radiculopathy. Okay, so next what happened? It involved all the other fingers.
It involved, yes.
No, wait, go back. Other fingers means what? There are 3 fingers supplied by median and 2 are supplied by ulnar. Isn't it?
Yes, sir.
So that other fingers includes ring finger and little finger or only the other 2
No, sir. It includes all other fingers, sir. Ring finger and little finger as well.
Okay. So now at this stage he has come to you saying that he has got involvement of all 5 fingers numbness. So now the question of carpal tunnel goes out because carpal tunnel only supplies the median 3 fingers.
Yes, sir.
So if the lateral 2 fingers, the ulnar 2 fingers are also affected, that means it is nothing to do with carpal tunnel. You understand?
Yes, sir.
So what is it now? It cannot be C6 radiculopathy also because C6 doesn't supply the little and ring finger. What is the nerve supply for little and ring finger? These are the things which you must read.
C8, C7, C8.
C8, T1. C8, T1. Okay. So,
yes, sir.
Cervical spondylosis rarely causes tingling numbness of the little and ring finger. So now what should we think of? So the 2 common things like the median nerve and the cervical spine radiculopathy is very unlikely. So we'd like to see on examination whether he has got any more findings. But at this stage, you should understand that whether we are dealing with a peripheral neuropathy on one side, like what we call as a mononeuropathy involving median and ulnar nerve, or there is something else coming up. See, that is the way one should start thinking about this. You have any questions or you're understanding what I'm saying?
Yes, sir.
Okay, next slide.
6 days later, he noticed some weakness over the right hand while he was working on the computer. Patient also noticed that he had difficulty in gripping the glass while he was drinking water. However, no history of spillage of water, difficulty while wearing clothes. He's able to mix food and have, but buttoning and unbuttoning is also he's able to do. He doesn't recollect having difficulty in writing.
Okay, now 6 days later, that means within 8 days of the within 6 days of the onset of illness. Now he has a weakness over the right hand. He has no sensory symptom.
He does have that. Yes,
Only
sir.
motor weakness.
Sir, he had numbness before. After that, following that, he developed weakness.
Numbness, you said, was only left side, no?
Sir, right, sir.
Huh?
Right, sir.
You told me go back to the first slide. Numbness over the left thumb, you said.
No, sir, right thumb.
Go back to the. Now you have changed it. The printout which you gave me was left thumb. Okay. So you have confused me. Okay. So it was all on the right side only.
Yes, sir. Yes, sir.
Okay, right. So the sensory has now extended to motor. So initially it was only sensory symptom. Go to the next slide. Now he has developed the motor weakness in the right hand, and the weakness is mainly for working on the computer and difficulty in gripping the glass. But he had no difficulty to button, mix food and all that. So what does this mean? Weakness for computer mainly. That means what? What muscles?
Task specific.
That means the digits, the fingers, flexors and extensors, they are not working properly. Because if you have to type like this, so you have to do these movements, isn't it? So when you have to do
Yes,
this
sir.
movement, there should be flexion, extension, flexion, extension. Mainly flexors are required. So that means again, this is the C8T1 flexors.
Yes, sir.
So now the sensory is becoming the motor, but the grip, the long flexors, to hold a glass of water, you require long flexors. So that is intact. So the person has now got sensory and motor. So the question now is this again sensory motor peripheral nerve or is in the root? We discussed when sensory was whether it is a median nerve, then we said it has extended to other fingers. So it is not median nerve. It is straddling across median and ulnar nerve. So
yes, sir.
whether it is a mononeuropathy, double multiplex. Now question of weakness, once the motor weakness comes, then you should be very careful whether it is a spinal cord involvement of motor weakness and sensory, which will tell us by examination. Okay, now next. Now, one second. In the previous slide, I said you don't have to do any major investigations. Give symptomatic therapy and tell him to come back when he develops any new symptoms. Now he has got new symptoms of motor weakness. The moment a patient has a motor weakness, he definitely requires investigation. So now we cannot say symptomatic treatment. Definitely we need to do a symptomatic, do to investigate. So what investigation you will do at this period of time? First you will examine and find out whether the motor weakness is lower motor neuron or an upper motor neuron, and accordingly you do a investigation. Okay?
Yes, sir.
Okay, next. Next slide.
10 days later, patient noticed that he had difficulty in walking. Difficulty as the patient had a tendency to sway towards his right side. However, patient hasn't sustained a fall anytime. Aggravates especially in the night or while he was walking in the dark spaces. Patient also noticed mild weakness while walking, such that he did not require any help to walk at that time. No history of stiffness of legs, slippage of footwear, no history of difficulty in guiding his foot through into the slippers.
Okay, now 10 days later, patient noticed that he had difficulty in walking. Now, what does this particular sentence tell us? You see, we were debating whether the patient has, first we said whether it is a median nerve at the wrist.
Yes, sir.
Then we said the 5 fingers are affected, then it cannot be median nerve. Either it is 2 nerves together or it may be in the neck with sorry, multiple roots involvement. That means we were in the peripheral nervous system, root or peripheral nerve. Now, the moment the patient has ipsilateral motor weakness in the leg, automatically the localization goes to the spinal cord.
Spinal cord.
Understand, this one particular sentence gives us such a valuable information that the patient has a spinal cord localization now, because you cannot have peripheral nerve right side and peripheral nerve lower limb. You cannot have C6, 7 and then L5, S1 both on one side. So the common sense says that all this can be put in one anatomical localization, that is in the cervical cord. You understand? So
Yes,
when a patient comes to you on day 1 or day 2, your thought process is different. But as the disease unravels, then it becomes more and more clearer. But the purpose of this particular talks to you people is how you will deal with him at that stage also. Because you can't expect every patient to come to you once there is a full-blown picture. So now this particular sentence has told that we are now looking at a cervical cord pathology. Then you said next sentence is tendency to sway towards his right aggravates in the night. So what does that mean?
sensory attacks. Yeah.
So he has got impairment of position and joint sense. Do you understand?
Yes, sir.
Impairment of position and joint sense. So he is unable to know where he is keeping his feet because the sensation from the joints and the position of the joint is not passed through the posterior column fibers. And so that means this patient had not only sensory fibers, motor fibers, now he also has got a posterior column fibers. Now I am using the word posterior column because now the localization is in the cervical cord. You understand?
Yes.
So now the cervical cord pathology is in the corticospinal tract, spinothalamic tract, and the posterior column fibers. You see how the neurology unfolds it is like a CBI inquiry. If you love the neurology, it is like a CBI inquiry now. So we are in the spinal cord, into the lateral column and posterior column. Now, then you said he has got mild weakness of while walking. So that obviously because the difficulty in walking, which you initially said, is the difficulty due to motor weakness or is due to a posterior column loss of joint position sensation or a combination which we'll have to look at during the examination. But one thing is very definite, the lesion is in the spinal cord, in the cervical region. Okay, next.
There was no progression over the next 4 days. At the time of presentation, that is 14 days later, patient had a right hand numbness and weakness, swaying to the right side, and mild weakness of the right lobe.
Now you said swaying to the right side. So is it a cerebellar?
No, sir. This swaying happens when he is in the dark. So happens only when the patient is in the dark.
That's not important. As I said, the neurology is tell me who your friend is. I will tell you who you are. If it is a cerebellar, the patient if he has got a dysarthria, then it becomes obviously cerebellar. If he has an incoordination in the upper limb, it is cerebellar. But here the friend is numbness of the right hand, weakness of the right leg, weakness of the right upper limb. So it cannot be cerebellar. In cerebellar, they don't come for weakness and numbness. They come for incoordination and hypotonia. So the friend here is not cerebellar. The friend is in the cervical cord. So that is a very important point. Remember, even cerebellar ataxia patients, in the dark, the ataxia becomes worse because already they are ataxic. and on the top of it, if they don't have visual cue, then become more ataxic. So that is a relatively less important symptom. But these are very important. Right hand numbness, right hand motor weakness, plus imbalance, that is a posterior column ataxia or sensory ataxia.
Yes.
Next.
No history of involuntary movements, recurrent falls or pain, no history of facial deviation, drooling of saliva, difficulty in swallowing, diplopia or blurring of vision. Now, no history of bowel bladder involvement, no history of prior fever, trauma, altered sensorium, or seizures.
Okay, so you have asked for symptoms of other cranial nerves.
Yes, sir.
Yeah. Next.
Past history, there was a history of painless loss of vision in the right eye 2 years ago, for which he had consulted an ophthalmologist. The loss of vision was restricted to the upper outer part of the field of vision. Patient had slowly had complete recovery of the vision over 6 months.
Now, what is this important story you are given?
Like painless loss of vision of the right eye 2 years ago.
Yeah. So, where do you get painless loss of vision? Do you get, what is the in optic neuritis? Is it painful or painless?
It is painful, sir.
It is a painful, isn't it?
Yes, sir.
So here he had a painless loss of vision, for which he consulted. A loss of vision was restricted to upper outer part. That means there is a report that he had a upper outer quadrant. There is a report, or he told you?
Sir, he told, sir. He told.
Okay. So, if there was a painful loss of vision, it would have helped us to say it is definitely optic neuritis. But it doesn't mean that every patient should have a painful loss of vision. It could be painless also. But as we are now into the spinal cord, it is possible that the patient might have had an optic neuritis. But you said patient had complete recovery of vision over 6 months. Did he receive any steroids? We don't know. So
don't know, sir.
the question is, can a patient of MS optic neuritis recover without steroids?
Yes, sir.
Don't say it in such a weak way. Yes, sir. Say absolutely yes, sir.
Yes, sir.
No, because steroids only hasten the recovery. First episode of MS, whether it is a spinal cord, brain, or an optic nerve, has a spontaneous remission. Spontaneous remission. Steroids will only hasten the recovery. So without any investigation, without any treatment, if the patient has recovered, that is a natural history of the disease. You understand? So it is quite possible it could have been an optic neuritis. But how do we know now it is optic neuritis? If you do an MR brain, particularly focusing on optic nerve, if you see a old demyelinating plaque in the optic nerve, it shows that he had an active demyelinating plaque in the past. So that is the only way to know whether the patient had optic neuritis or not, to see the old demyelinating plaque. Okay, now it has given us more teeth to say that the localization is in the cord, intrinsic cord, because possibly it was a first episode optic neuritis, and this is a recurrence in another location, that is the cervical cord. Okay, next.
Personal history, appetite normal, sleep adequate, bowel bladder was normal. Family history, no history of similar complaints in the family.
Next.
Neurological examination, patient is conscious and alert, higher mental functions were normal, no spinal cord deformity noted, cranial nerves examination was normal, bilateral.
Spinal cord deformity. How can you make out spinal cord?
Spinal deformity, I'm sorry.
Yes, sir. Spinal deformity.
Spinal deformities.
Okay, good. So these are all normal.
Motor
functions, cranial nerves. Now,
yes,
specifically, the pupil and the vision, both are normal?
Yes, sir.
Because
vision Okay.
Of course, you may not be able to appreciate, but in the clinical examination, the old optic neuritis can be seen as a pale disc. Even though the patient might have recovered vision 6/6, the disc may look a little pale compared to the other eye. That is a telltale sign of old optic neuritis. So, very specifically, one should look for optic discs and compare with the other eye. That is another evidence that the patient had optic neuritis in the past. Okay.
Motor system examination, bulk normal bilaterally, tone was normal.
Okay, next slide, next slide. Okay.
So there was weakness in the wrist flexion, extension, and finger grip on the right sides.
Right. So he has got right-sided distal weakness.
Yes.
Right. So distal weakness can be UMN or LMN. But in this case, because we are saying that it is a spinal cord, probably it is a UMN. But more signs for UMN, let us see.
Lower limb, also right-sided knee flexion extension were weak. Plantar flexion and dorsiflexion were also weak, and bilateral Babinski was extensions.
Okay, next.
So reflexes, upper limb reflexes were normal, sir. In the lower limb, knee jerk was knee reflex was brisk, and ankles were exaggerated. No clonus was seen on the right side.
So all of upper motor neuron signs.
Yes, sir.
Okay, then sensory.
So coming to sensory system examination, reduced pinprick and cotton touch sensation over the right hand till the mid forearm, and also reduced pinprick and cotton touch sensation on the right side of the trunk below the nipples.
That means entire right lower limb also, or only in the chest, that's all.
Yes, sir. Only in the trunks. Bilateral lower limb sensations were normal. Cortical sensations were normal. Romberg sign, swaying to the right side with closed eye. Other cerebellar signs were negative. Mild in gait, mild right-sided gait ataxia was seen.
Okay, there were some sensory symptoms. Right hand till right forearm and right side of the trunk. Trunk means what? Below the nipple means about T4 down up to the anterior superior spine.
Yes, sir. T4 down. Yes, sir.
Okay. Okay, next.
Neurological deficits, right hemianesthesia below T4 and over the right upper limb till mid forearm. Right sensory ataxia with right hemiparesis. Past history which is suggestive of query optic neuritis. This is neurological deficits. Anatomical localization, probably lower spinal cord lesion.
Can you be more specific?
Sir?
Okay, now
at
right anesthesia and right sensory ataxia. Now, where is the lesion in the cervical cord? Intramedullary or extramedullary?
Intramedullary.
Intramedullary where? Right side, left side?
Left side, sir.
Huh?
Left side, sir.
Think again. The motor is always ipsilateral, no?
Yes, sir.
Corticospinal tract, after crossing at the lower part of medulla, supplies the same side of the body. Yes, so if the patient has a right-sided UMN weakness of upper and lower limb, that means the right side of the cervical cord, corticospinal tract on the right side of the cord is affected.
Yes, sir.
Then what about the sensory? Sensory is same side or opposite side? Anybody in the chat?
Opposite.
What, madam? Opposite side.
Opposite
Yeah,
side,
somebody
sir.
has said, one plus person has said opposite side. See, that is a, you must have read about Brown-Sequard syndrome and hemianesthesia. Same side motor paralysis, opposite side sensory paralysis. If it is a cervical cord or a spinal cord, same side will be motor weakness, because the spinothalamic, as soon as they enter the cord, they cross and go opposite side. So the patient has a right-sided motor weakness, so right corticospinal tract, right-sided sensory ataxia. Now, is it on the right side posterior column or left side posterior column? Anybody from chat?
Right
Posterior column,
side.
same side or opposite side?
See.
Yeah, thank you. Same side.
Same.
So spinothalamic is opposite side. Corticospinal and posterior column is on the same side. Now this patient has a predominant corticospinal and posterior column. That means the predominant lesion is on the right side. And remember, posterior column also carries touch sensation. You understand? Not the pain or the temperature, but the touch sensation. In addition to the position and vibration, they also carry the cotton touch or touch sensation. So if you find the sensory, the pin is normal, temperature is normal, only the touch is reduced. So it is also part of posterior column dysfunction. That means the entire pathology is on the right side of the cervical cord, affecting the corticospinal and the posterior column. But in case, without any doubt, the patient has pin and temperature also is gone. That means in addition to right side cervical cord lesion, the patient also has on the left side spinothalamic lesion. It is not strictly unilateral, it is also on the other side. So that is what we want you to understand in the examination. These are the questions we'll ask you. Ipsilateral corticospinal, ipsilateral posterior column, contralateral spinothalamic. So if you have found mild cotton touch sensation is not there and posterior column and corticospinal, everything is on the right side of the cord. Okay, next. But what level you have not said? What is the highest level you have found? You have found a distal weakness in the hand. That means it is
Hand.
C8T1.
Yes, sir.
And biceps is normal,
C8T1.
triceps is normal.
Yes, sir.
So biceps and triceps is normal. If triceps is exaggerated, the lesion is above C7. If biceps is exaggerated, it is above C5. If both are normal, it may be at the lower cervical cord, maybe at 6 or 7.
6.
So the localization is intrinsic spinal cord on the right side at the level of C6-7. So that is how you must localize the lesion. You have done it very well. Lower cervical cord, intramedullary, but a little more specific on the right side, affecting corticospinal and posterior column predominantly, plus minus spinothalamic on the opposite side. Okay, then you said pathological.
What about the sir, about the sensory level in D4? How does that come?
Pardon?
That's sensory level in D4, sir. About that?
Yeah, if the patient has sensory level on the right side only, or both sides?
Oh, yes, sir. No, sir. Hemi anesthesia. Yes, sir.
Hmm?
Only on the right side.
Only
on the right side.
Yeah, again, same. Is it only for cotton touch? In which case it is a posterior column. But if it is a definitely pin and temperature also affected, necessarily it has to be on the opposite spinothalamic tract. So the lesion is not heavy. The lesion is across the midline. So you will have to determine whether they will go back and see on the sensory. Is it only a mild touch which is gone and a little bit of pin only, but temperature is well preserved? Then spinothalamic is intact. But otherwise, the spinothalamic on the other side is also affected. But predominant lesion is on the right side, extending to the left. That's what we have to say. Now, pathological, you said demyelination and jump to AV malformation. AV malformation is a very, very rare diagnosis. Very rare. Please remember, whether you are a professor of neurology or a director of NIMHANS, always think of common things first. We use the word common because they're commonly seen. So, very rightly you have said a demyelination. Now, once you have said there is a intrinsic spinal cord disease, there are hardly 4 or 5 diseases intrinsic spinal cord.
Yes. Astrocytomas.
Somebody is asking, is there a reduced joint position and vibration in the lower limb? If sensory ataxia, no sir. Sensory ataxia means posterior column involvement. So there should be vibration and joint sensation must be affected. Then only we call it as sensory ataxia. Sensory ataxia does not come by spinothalamic tract. It comes by posterior column, where position, joint sense, and mild degree of cotton touch impairment will be there. Okay, demyelination is very correct. Can you tell other intrinsic cord lesions? Okay, I will tell you. Demyelination is the
Astrocytoma, ependymoma.
Other things are, you have written one more. Glioma, that is astrocytoma. Yeah. Tuberculoma. What about transverse myelitis? You have not written transverse myelitis, no? So I'll talk to you about differentiation between transverse myelitis and demyelination in my next talk. So demyelination is one, tuberculoma is very important, very common in our country. Glioma is another thing very common. Then transverse myelitis. These are common features which have come within a few days. And rarely there may be rare diseases like AV malformations. AV malformation can present like this, but their occurrence is so low. You should always think of common things. You have talked about two things: demyelination, astrocytoma, that is a glioma, tuberculoma, don't forget, occasionally cysticercosis. Then, of course, transverse myelitis is a very important differential diagnosis. Somebody is asking how lower cervical cord anatomical localization. Yeah, what is the motor? Patient has got a distal motor weakness. In the upper limb, what she said was distal motor weakness, but there is no motor weakness in the shoulder and elbow region. So the distal is C8T1. So obviously it is a lower cervical cord affecting at the level of C6 or C7, which can cause the right lower limb weakness, the right upper limb hand weakness. Suppose the patient had a triceps reflex exaggerated with normal biceps, that means if side triceps has to be exaggerated, the lesion should be above C7 nucleus. So you can definitely say it is at C6. If biceps also is exaggerated, it is above C5. So that is how we go step by step. Here we have only localization for hand weakness. So we are going at lower cervical cord. Yeah, of course. Hand weakness is there, lower cervical cord. Remember, the lower cervical cord is driving the corticospinal tract to the lower limb also. In the same side, the fibers to the hand and the fibers which are going down to the right lower limb is also affected. That is why the patient has got a ipsilateral right lower limb weakness. So at that level, cervical cord, right upper limb, right lower limb, if there is a total transection of cervical cord, then you get a quadriplegia. Now, how hip power is 5/5? If you remember my earlier teachings, distal motor weakness is very characteristic of UMN as well as LMN lesion. So even though the patient has a right lower limb UMN paresis, the distal motor weakness is more than the proximal, or proximal may be normal and only distal will be affected. If you see the patients with hemiplegia when they come, how do they have? They have a distal motor weakness. In upper limb also, the last thing to recover is the hand. They recover the elbow and shoulder. And the last thing to recover is the hip, the foot. You'll see that the patient has a circumduction gait because the right foot is weak. So distal motor weakness is characteristic of upper motor as well as lower motor neuron. Proximal motor weakness is very characteristic of a muscle disease or a motor root involvement. I hope you have understood. Somebody who said in the chat. Did you get my answer? Okay, next. Next slide. So the two investigations is investigation of choice for anatomical localization and investigation of choice for etiopathological diagnosis. Anatomical localization, we have made it as cervical cord. We have to see specifically in the cervical cord transection whether a lesion is more on the right side or exclusively on the right side. Okay, tell me.
Sir, this is a non-contrast MRI, sir. So all so they have hyperintensity is noted in the cervical cord from here in around C2, C3 region, sir, and also in the C2, C3 region.
It is very much seen in the C2, C3, but it is
Yes,
faintly seen even down below. You can see right up to this 2, 3, 4, 5, 6, up to 7. You can see faint lesion is there. If you had given contrast, you could have seen better. Contrast was not done.
So contrast was not done. So this MRI was done outside. Then when they came here, they refused to for a repeat MRI as well.
That is why I keep telling you, when you ask for an investigation, you must have a clinical diagnosis. The clinical diagnosis, demyelination or transverse myelitis, both are inflammatory disease. Inflammation means increased vascular permeability. You must ask for a contrast. You must, even if it is a glioma, you must ask for a contrast. Tuberculoma, you must ask for a contrast. If the patient has got clinical diagnosis spondylotic myelopathy or motor neuron disease, you don't have to ask for a contrast. So what you ask for depends on what is your clinical diagnosis. So in this patient, one should have asked automatically for plain and contrast. Contrast would have given you the full length of the, how you understand what investigation to be done, plain or contrast, depends on your clinical diagnosis. Okay, do you have the cross section?
Yes, sir.
Yeah, you can see in one of these, more on the right side here.
Yes, sir.
You can say, can you show it? Because I cannot show it. With your pointer, you can show.
I'm showing.
Yeah,
I'm
that is
showing,
one,
sir.
which is the white one which is there. That is the demyelination. It is more towards the right. That's right. Okay. So now it is confirmed that there is an intrinsic cord lesion, C3, 4, but we are not seeing at the level which we want to see, probably because the patient did not have a contrast, so we don't know about it. But remember, the lesion may be there radiologically, but clinically the lesion is above the level of C7, C8, lower cervical cord. Next slide.
The same pictures.
Yeah, now this blown up picture shows a demyelinating plaque. Now you see the posterior columns. If you see the demyelination, it is bang onto the posterior side, the posterior column. You see the anteriorly it is unaffected. It is basically in the posterior part which is affected. That is very typical of demyelinating multiple sclerosis, which affects the posterior column and corticospinal tract. It's very classical of multiple sclerosis, less of spinothalamic, more of corticospinal and posterior column. So if somebody gives you the MR scan, you can say that this is not only a lesion there, but because it is predominantly on the posterior side, it is highly suggestive of AMS. Next. So whenever you find a patient has come for cervical myelopathy, the diagnosis is, the radiologist says that there is a demyelination. automatically the radiologist must ask your permission and do a MR brain and MR optic nerve. That is a must because it adds to the diagnosis of MS. After all, MS is multiple localization. So unless you do a MR brain and show that there are lesions there, which might be asymptomatic because patient never had those symptoms. Do you find any plaques in the? I don't
Yes, sir.
see.
Right temporal plaques and periventricular plaques as well.
Where is periventricular? I'm not seeing anything. Periventricular. One more slide is there?
No, sir.
No.
And in the right thalamus as well.
Thalamus, madam, is a gray matter and demyelination is a white matter disease. Do you understand?
Yes, sir.
You don't get demyelination in thalamus. Thalamus is a gray matter. So the MS is a white matter disease because myelin is only in the white matter. Myelin is not in the gray matter. So what you see in the thalamus, that dot there is not a demyelination. It may be a small infarct or whatever it is, or we don't know what it is. But I don't see any demyelinating plaque in the figure which you have shown. Usually it is periventricular and perpendicular to the ventricle. So that is what is characteristic. But the point I am trying to make is when you make a clinical diagnosis of probable demyelination, give a request MR cervical spine, plain and contrast, and screening of thoracic spine, thoracic spinal cord, and brain. Usually I ask them to do after contrast because otherwise everything is 6,000, 6,000, 6,000. So after giving contrast, you also screen the thoracic cord to see there are 2-3 level of lesions and also the brain. Ideally, plain and contrast brain, plain and contrast spinal cord. But to compromise on the economy, after the contrast, you have to do brain and the rest of the spinal cord. So here we do not have this thing. You're finished? Important. Next investigation is CSF.
CSF, it was colorless and clear. Cell count was 4. Cell type of 90% lymphocytes. Proteins and glucose were normal. CSF for oligoclonal bands was positive.
Right. So the most important point is even though there is no inflammatory response because cell count is only 4, protein is normal, glucose is normal, all the parameters are normal. But the most important investigation is the presence of OCB, oligoclonal bands. But where is the serum oligoclonal bands not done?
Yes, sir, it was done, sir.
So is CSF more than the serum?
Yes, sir.
Because very important, just if you do only oligoclonal bands of CSF is not diagnostic. This oligoclonal bands or this abnormal protein should have been produced in the nervous system. To say that it is a demyelination, the protein should be high in the CSF as compared to the serum level. Suppose serum is high and CSF also is equal, then it is only a transfer from blood to the CSF. So it is always important to do serum as well as CSF OCB, and CSF OCB is higher than the serum. That means it is produced locally. That means there is a local inflammatory pathology. So that is another important point you must think about. Okay, what is this?
Visual evoked potential, so bilateral optic nerve demyelination along pre-chiasmatic pathways was seen, sir. Right was more than left.
1 minute. VEP will not tell you there is an optic nerve demyelination. If somebody has written that, it is wrong. Demyelination is a radiological diagnosis. It is not a electrophysiological. VEP will only show delayed conduction. It is like nerve conduction. Like nerve conduction, I think today it is very, very generous. It's already 52 minutes and they have not cut it so far. Very good. I think you have brought some influence, I think. Okay. So it will only to show that there is a delayed conduction of the visual pathway. So the report should be right optic nerve and left optic nerve dysfunction. So that means even though the patient may have 6/6 vision today, investigation wise, there is a delay in the conduction. As an indirect evidence, the patient had an optic neuritis in the past. Indirect evidence, patient had optic neuritis if the disc is pale. Indirect evidence if there is a demyelinating plaque in the optic nerve. For example, in this patient, we do not know whether they have taken a dedicated MR optic nerve. Then only you will see there is an optic nerve demyelination. In the MR brain as a whole, you may not be able to pick up the demyelination in the optic nerve. Okay. So anyway, the CSF OCB has to be confirmed, that serum and CSF has to be compared. And the very fact the patient has optic nerve dysfunction shows that there is a definite involvement of optic nerve in the past. Next.
That's all.
It's over. Okay, now tell me, why do you say this is what is your diagnosis, final diagnosis?
Sir, it is could be second attack of MS, sir.
So what type of MS it is?
So relapsing remitting MS, RRMS.
Yeah, it is a RR. What is the commonest type of, what are the types of MS?
The RRMS is the commonest type.
What are the other types of MS?
Other types are primary progressive MS, benign progressive MS, secondary chronic progressive MS, and that's it. Acute MS.
Okay.
Marburg's variant of acute MS.
When I share the screen, in case the screen stops, I will have to record the whole thing. So it may take about 15-20 minutes. So I'll come back to you after 15 minutes or so. And until then, I can take over the screen. Okay?
Okay, sir.
Akshay?
Sir, you're not audible, sir. You're not audible, sir. It's muted.
All through, I am not audible up till now.
Sir.
You are not. I was not audible for all these slides.
No, sir.
Oh my God. So I'll quickly go through the intramedullary parenchyma bladder is first. Okay. In. Okay, you should have told me at the very first slide. Okay, this is the differentiation between intramedullary and extramedullary. And this is the transverse myelitis and MS, how they look MR wise. Transverse myelitis, you see the full thickness of the spinal cord, which is affected. There's an infection. Whereas in multiple sclerosis, only one segment, that is one vertebral body. That's all. If there are three vertebral bodies, then it becomes NMO, neuromyelitis optica. If it is transverse myelitis, the full thickness of the cord is affected. That is how the differentiation radiologically. And you see here, it is self-explanatory. MS will cause posterior column and lateral column. Transverse myelitis, the entire thickness of the spinal cord. Anterior spinal artery thrombosis is in the anterior. B12 deficiency, again, there is a posterior column predominantly. This is just a picture of spinal tuberculosis. Now this is the syringomyelia which I was talking to you about. There's a huge syrinx is there. Now when you see a paraplegia, MR scan shows compression, surgical. There is no compression. There is an intrinsic lesion, do a CSF. So it is intrinsic lesion is inflammatory. Intrinsic lesion, normal CSF, either it is an anterior spinal artery infarct or a paraneoplasty. If there's a patient has paraplegia or quadriplegia, all these are normal. Check your diagnosis. It may not be really spinal cord. It may be periodic paralysis or myositis. When you are still confident, repeat MR scan after 24 hours, you may find it. Now in the demyelinating disease, once we saw a demyelinating disease, radiologically, there are four types. One is ADEM, acute demyelinating, and multiple sclerosis, NMO and NMOSD. The main confusion is between MS and NMO because the treatment is entirely different. Whereas multiple sclerosis requires disease modifying therapy, NMO is a humoral antibody, whereas MS is a cellular antibody. So the treatment is different for MS and treatment is different from NMO. Not the acute. Acute one is, of course, as I keep telling you, Gangajal, steroids. It is for disease modifying where they're totally different is there. So in MS, we have multiple sclerosis. That means there are multiple sites and multiple timings. The multiple sites are optic nerve, brainstem, spinal cord, and brain. So whenever you see spinal cord pathology, you must look for the other lesions. And not only the multiple sites, it is also multiple timings. That means 1 year ago, 6 months later. Suppose all the multiple sites have come at one time, then it is not multiple sclerosis. It may be secondaries, it may be vasculitis. So all of them have come at one time. It may be multiple tuberculoma, multiple abscesses, but it is certainly not multiple sclerosis. So two criteria. One is multiple timings, another is multiple locations. According to the McDonald criteria, there are four types are there. The first episode is called as clinically isolated syndrome. Why do we call it as clinically isolated? Clinically, they come for paraplegia, but radiologically, there is a lesion in the brain, but that is asymptomatic. But clinically, it is definitely MS because there is one radiological feature is there. So it is a clinically isolated syndrome. The commonest is what we saw in this patient, RRMS. Rarely you see secondary progressive. That means there are 2 or 3 episodes and then it continues to worsen. There is no remission at all. Very rarely we get a primary progressive. That means right from the word go, it is a slowly evolving into a chronic disease. So these are the 4 varieties. So this is important point to remember that MS is a inflammatory demyelinating pathology, and the difference I will come to later. So when you see a patient with MRI spine showing demyelination, as I already told you, you should ask for MRI brain, optic nerve, plane and contrast, VER, to know whether myelopathy is isolated or is it MS or NMO. In neuromyelitis optica, nerve, optic nerve and spinal cord is MS, brain is also affected, brain stem is affected. So that is a differentiation between NMO and MS. Now you see this demyelinating plaque here, and you see the demyelination in the brain stem, in the brain. You see the perpendicular lines at 90 degrees to the ventricular surface. So these are the demyelinating plaques which you see in the brain. Now, how do you differentiate a transverse myelitis from MS? I showed you the radiologically full thickness is transverse myelitis. Very small lesions are in the MS. Transverse myelitis is a devastating spinal cord disease where there is a sensory, motor, and bladder. All three components are involved. Whereas in MS, it may be predominantly motor, predominantly sensory, or at times bladder. All three are rarely affected in MS. MR thoracic cord I have already shown you. MR brain will be normal, obviously, in transverse myelitis, but there will be demyelinating plaques. Past history of illness nil. CSF will show both inflammatory response, obviously. Oligoclonal bands will not be there in transverse myelitis. So that is how you differentiate one from the other. But the acute management remains same. Then clinically isolated syndrome or the first episode of RRMS, acute management is same. Remember, even without steroids, the patients will improve as in this patient has done. After the acute episode, what are the chances of getting another episode? Because of that only we are giving the disease modifying therapy. The chance of another episode is about 60 to 70% within 6 months. And within 2 years, almost 90% of them develop another episode. And remember, with each episode, the lesion is more and more devastating. And that is the reason why even with first episode, we recommend disease modifying therapy in MS. So hence there is a need for DMT. So acute episode, 4 things: steroids, Plex, IV, IgG. So we give steroids, standard dose, 1 gram 5 days, plasma exchange or IV IgG. But remember, spontaneous recovery does occur. Prognosis, more than 30% will develop physical disability. That means if you look at the other way around, 70% of MS do not go to the wheelchair, because the moment you diagnose wheelchair, they will go to Dr. Google. And then in all MS, everybody will be seen with wheelchair or bedridden. So every patient thinks that they are going to reach that stage. No, not necessary in a large number. That means nearly 70% of people will continue to have RRMS with a minimal disability. Not everybody will be wheelchair bound, which is very important to stress to our patients who are all Google educated. So anyway, to prevent further disease, we have disease modifying therapy. And now at one time we didn't have anything except interferon. Now we have oral drugs also, quite a few oral drugs, quite a few parenteral drugs. But currently the favorite is rituximab. Earlier we used to give interferon, this natalizumab and all. Now the current favorite is rituximab, simply because it is easy to administer once in 6 months, and also it is much cheaper than other drugs which has to be given more frequently. Now, how do you differentiate NMO from MS? Now that is a very important clinical point. Now if the Zoom shuts down, I'm not going to have a second session because I have almost finished it. So we'll say goodbye to you, and next Thursday we'll meet. Now the last 2 slides. Multiple sclerosis is a cell-mediated disorder, whereas NMO is a humoral immune system. So this requires immunosuppressive drug. Which one? NMO requires immunosuppressive drug to prevent a relapse. Now, what are the immunosuppressive drugs? Azathioprine, mycophenolate, and we have our rituximab. So rituximab works for both, but azathioprine and mycophenolate works only for NMO. It does not work for MS. The other MS drugs like interferons do not work for NMO. So you must be very clear about your diagnosis. Acute treatment steroid for both. Today chronic treatment rituximab also for both. So if you are not sure, go for acute treatment steroids, chronic treatment rituximab. But if you want specifically, you must make a proper diagnosis. Now, how do you differentiate? NMO, obviously it is only the optic nerve and spinal cord, whereas the MS will be optic nerve, spinal cord and brainstem. OCB positive here, here NMO positive. NMO or aquaporin antibody. Sometimes when it is negative, there is another antibody, myelin oligogandocyte. So that is a MOG positive. And the course are recurrent RRMS, not necessarily progressive. So these are the different varieties of differentiating between NMO and MC. So, well, I have uploaded 10 clinical cases and 18 talks. If any of you want me to give a talk on any particular topic, please let me know. I will think about it and talk to you. Until we get another talk to be given, we'll continue the clinical cases. And those of you who are new, please buy Clinical Neurology Made Easy. Very, very important for you to understand neurology. The next class is on the next Thursday. So one of my residents are going to present. If any one of you want to volunteer, you can please say so in the chat. Otherwise, everything else remains same. The meeting ID, the passcode, everything, the timing, everything, every Thursday. So now you have any questions because I have rushed through the last couple of slides. If you have any questions, I will clarify it. And I'm very happy that Zoom this time has given me so much time without any pause. Any questions from the chat people? The important is to diagnose NMO from MS, and in the NMO, if aquaporin antibody is negative, you still consider it as NMO. You must also get a MOG antibody. Now, what is the difference between NMO and MOG type of antibody? MOG IgG and NMO IgG is that MOG is a monophasic, so it requires no further treatment. Look at the down column. MOG antibody, patient has come for a more than 3 segment spinal cord pathology and an optic neuritis, and you did a aquaporin antibody or NMO antibody, what we call it is negative. You do a MOG and it is positive, then you don't have to give any further treatment. No disease modifying, no immunosuppressive, nothing. And the prognosis is very good because the disease is moderate. But if the patient has NMO positive, then you have to give immunosuppressants like azathioprine and MMF or rituximab, as I told you. So, any doubts, clarifications? And anybody wants to present? You see the difference between NMO and MS. These are the points which they will ask you in the examination. DMT in MS, how long it should be given? Okay, this is a very tricky question. At the moment, indefinite. People say lifelong. But what we usually do in practice is, if the patient doesn't have a relapse for 5 years, because most of the relapses occur in first 2 years, some people even in third year. So if the relapses has not occurred for 5 years, earlier 10 years ago, 2 years no relapse, we used to stop because maximum relapse occur in first 2 years. Like in TIA, maximum stroke occurs in first 2 weeks to 3 months. After 3 months, there is no need for doing any carotid intervention. That's what I told you in the stroke last time. So here, if the patient has no relapses for 5 years, or suppose the patient had a clinically isolated syndrome, and for the next 2 years there is no relapse at all, then I will stop after 2 years. But if the patient had 2 episodes or some disabling episode, then I may extend it up to 5 years. So 5 years, no relapse, you can stop it. But textbooks will say lifelong or indefinite. Any other question? These are all day-to-day problems. I thought you will have more questions. Anybody wants to present a case? How frequently we should have MRI surveillance? There is no need for MRI surveillance. There is no need to do repeat MR scan if the patient is not having any clinical relapses. Absolutely not required. So if the patient has a relapse, then if the patient has another neurological event, whether this is due to a relapse of the patient, relapse of the disease, then you have to do an MR scan. Otherwise, you don't have to do an MR scan to see whether the lesion has disappeared or not. It won't disappear. It may be there permanently. So there's no need for repeat MRI scans at all. Though I know some people do it in the clinical practice, but there's no rationale in doing another MR scan. What are you going to do after another MR scan? If the patient doesn't have any new symptom, why do you want to do an MR scan? You don't give steroids because there is MR scan is abnormal, nor you give disease modifying therapy because MR scan is abnormal. You have already decided that the patient requires disease modifying therapy. So no need for MR surveillance. MR surveillance, if you mean more areas of MR, yes, if patient comes with optic neuritis, MR brain, MR spinal cord. If patient comes for some cerebral localization, MR optic nerve and MR spinal cord. If patient comes with paraplegia, MR brain and MR optic nerves. So out of the three, one symptom, two MR surveillance to see whether there was radiological evidence of spread of the disease. Anybody wants to present case? Nobody. Okay, so let me thank the Zoom for having given us this one. So we'll meet next Thursday. Meghna, any questions for you? Any follow-up of that patient, Meghna? Meghna is here, has disappeared.
No, I'm here, sir. I'm here.
Any follow-up of the patient?
No, sir. No, sir. We had sent for NMO and anti-MOG, but patient never turned up to show the reports.
I didn't understand. Patient had NMO test done?
No, sir. We had sent for it. So at the time it was awaited. After discharge, he didn't come back for follow-up.
Okay. So we don't know the follow-up also. He should do well because very minimal neurological deficit. But for me and you, it is a minimal neurological deficit. But right hand is so important for day-to-day living, khana, pina, computer, everything. So writing, signature, so many things. It is very important, right hand. So for him, it is a disability. So for you and me, you say only grade 4 power, minimal disability and all. So the person who has disability knows what is the problem. Okay then. So if none of you have questions, I will close it. Bye-bye and good night. Meet you next Thursday. Meghna, you see that next Thursday, either you or your friend will present. Okay?
Okay, sir.
Right. ಇಲ್ಲಬೇಕು ಇವತ್ತೇನು 1 hour ಕೊಟ್ಟಿದ್ದಾನೆ